Welcome to all of you. For those of you who don't know who I am, I'm Mitch Sadar. I'm the president of the board of NRBS. And then on the behalf of the board, I welcome you all here today. I will say a couple words about NRBS, and then we will get on with what I believe will be a very good show. Uh, I I urge everybody, if you are not a member of, NRBS, please join us because it will allow us to do more things. Everything that I'm about to talk about, you can find in the NRBS website, and also Ronnie will be putting links in the chat. I want to mention our Connect Tuesdays, which is the first Tuesday of the month. This is where we are getting together to talk about ways to unify and to, advocate for the biofeedback, neural feedback field. And I really urge everybody to think about checking that out. I want to make people aware that this year's conference is going to be in New York City. We've got big plans. The conference date is October 24th to the 26th. You'll be receiving, information about that. I also want to put a plug in to Dr. Saul Rosenthal's podcast, Healthy Brain, Happy Body. People that listen to that really like it. Dr. Schaffer has already done one for us, and you can hear some more from him uh, in 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 that podcast. Okay. I will also say this: those of you who have been to these in the past know that the way that we like to run them, put your questions in a chat. I will be monitoring those. We will save time at the end to look at those. If there's anything that seems to be really urgent, I'll then voice it. But in general, please put them in the chat. Okay, on with the show. Dr. Fred Schaefer is a biological psychologist who frankly knows more about breathing and HRV than anyone else I know. He has taught at Truman University since 1975. He provides online education in neurofeedback, biofeedback, and QEEG through his company Biosource Software. He has trained people all around the world. He is very active, and he has been very active in AAPB and BCIA. He has, edited books and journals. You can read more about this gentleman and his accomplishments in the bio on our website. We are lucky to have him speaking today. I am lucky to know Fred personally, and along with being very accomplished, he is one of the nicest people that I know. So, Fred, take it away.
Well, thank you. Uh, you are extremely kind. I want to focus on some other folks. I have learned so much from Doctors Ina Khazan, Christopher Gilbert, and my long time collaborator, Don Moss. You might ask, why a Breathing Myths webinar? And my answer would be, again, from amazing colleagues, Dr. Richard Gevirtz, Ina Hazan, Linda and Michael Thompson, have taught me that healthy breathing is an indispensable foundation for successful biofeedback and neurofeedback training. And it's important to dispel clinician and client breathing myths to unlock the full potential of this intervention. Uh, we will cover the basic breathing science and myths. Here are the educational objectives that you can read for yourself. Enough about me, APA guidance. This time around, I have promised to respect copyright. And I want to just let you know that I have some foundational material about the science of breathing. I will not cover it in this presentation because I want to focus on the myths and get your questions. But this is in the handout that you've received, and you will find it useful as a reference. So I'm just going to skip through it to show you what you can look up after my presentation. But it shows some of the foundational information about breathing science as opposed to breathing myth. One of the cool things I will mention is hemoglobin. It is the transporter molecule that is found on red blood cells. It transports oxygen, it transports nitric oxide. Now, this is what I geek out about. Each individual red blood cell contains 270 million hemoglobin molecules. And each hemoglobin molecule can carry 4 oxygen or 4 nitric oxide molecules. So what this means is that a single red blood cell can carry over 1 billion oxygen molecules when it's fully saturated. And again, please look at this after the presentation. It will give you my receipts, basically, the facts that the presentation is based on. And crucial to these facts is the Bohr effect. And this means when we have a healthy level of carbon dioxide in the blood, we are able to release oxygen and nitric oxide to our tissues where they're needed. And now I would like to go to our questions, the myths. And the very first myth is carbon dioxide is a toxic waste gas we should remove. First, out of the box, CO2 is not toxic in the concentration the body produces under normal conditions. But it is crucial for the human body's respiratory and cardiovascular systems. It is a key part of our buffering system to maintain optimal pH. And pH stands for the power of hydrogen. Now, the concentration of CO2 in the blood regulates breathing rates. Low levels of CO2, we call this hypo, meaning under capnia, can lead to respiratory alkalosis, which means increased pH. On the other hand, high levels, hypercapnia, stimulate breathing to remove excess CO2. All of this in the service of homeostasis. CO2 is essential for the Bohr effect that I mentioned a few moments ago. And this describes how the presence of CO2 facilitates oxygen release from hemoglobin, enhancing nitric oxide and oxygen delivery to the tissue. And nitric oxide is important because it dilates blood vessels. And when you don't have sufficient CO2 because you're overbreathing, your blood vessels in the brain and in the heart will constrict. And this can provide a wide range of symptoms. So this effect, the Bohr effect, demonstrates CO2's critical role in ensuring that we efficiently supply oxygen and nitric oxide where they're needed in the body. And we typically need about levels of 35 to 45 millimeters of mercury, or torr, to maintain homeostasis. N-tidal CO2, by the way, means the percentage of CO2 at the end of exhalation in your exhaled air. So here is my first webtoon. Myth: carbon dioxide is a toxic waste gas that we should remove. Fact: while CO2 is a byproduct of metabolism, the body requires 85 to 88% CO2 to regulate pH, deliver oxygen and nitric oxide to tissues, and stimulate breathing and dilate blood vessels. And in case you haven't seen the similarity, that is Dr. Ina Khazan. Myth 2: we need more oxygen. Now, under normal conditions, most people's blood is already saturated with oxygen, somewhere between 95 and 100%. The issue is not the amount of oxygen in the blood, but how effectively we use it. And this is influenced by factors like the Bohr effect, where CO2 levels help to release oxygen from hemoglobin. So if you blow off too much CO2 because you're overbreathing, your oxygen is not going to get where it's needed. Rather than needing to maximize your intake of oxygen, the real concern is maintaining adequate levels of CO2. Now, overbreathing, which may be the most common breathing dysfunction, expels too much CO2. This leads to a condition called hypocapnia. This can reduce blood flow to the brain and impair oxygen release by hemoglobin, paradoxically leading to symptoms of oxygen shortage. Now remember, when we reduce blood flow to the brain, there's a whole range of symptoms that the patient may present with. It clearly will interfere with our executive functions and clearly will interfere with optimal performance. Dr. Kazan takes responsibility for that exclamation point. She has clearly said, we do not need more oxygen. Near sea level, the air that a healthy client inhales contains 21% of oxygen, while the air they exhale has 16%. So we only use a quarter of our inhaled oxygen, and we don't need more. Instead, we need to conserve CO2 by retaining 85 to 88% of it. Myth: we need more oxygen. Fact: we only use 1/4 of inhaled oxygen and don't need more. The issue is CO2, not oxygen. We must conserve 85 to 88% of our CO2 to deliver nutrients and remove waste from our tissue. Myth 3: oxygen intake is the primary role of breathing. This is a myth because it oversimplifies the complex functions of the respiratory system. Now, there's no question that obtaining oxygen is crucial to breathing. It's not the sole purpose. Equally important is exhaling CO2 a byproduct of cellular metabolism. Removing CO2 from the body is critical for maintaining acid-base balance in the blood, preventing acidosis, which means decreased alkalinity, and ensuring that cellular processes function correctly. Breathing plays a critical role in regulating blood pH. By simply adjusting the rate and the depth of breathing, the body can control the amount of CO2 expelled, directly influencing the blood's acidity. This regulation is essential for the proper functioning of enzymes and metabolic processes. I stole this table from Chris Gilbert, and it shows how CO2 regulates blood pH, and we simply redrew it. And this, on the far left, you have different pH levels, end-tidal CO2 levels, and then the effects. We strongly recommend that you avoid the extremes, which involve death and coma. Normal around 40 is desirable. Breathing supports the efficient exchange of gases in the lungs by way of the air sacs or alveoli. And this is where oxygen is absorbed into the bloodstream and CO2 is released for exhalation. This exchange is crucial for metabolism and energy production within the cells. Myth: oxygen intake is the primary role of breathing. Fact: although oxygen intake is crucial, breathing regulates CO2 levels, which maintain the body's pH balance, deliver oxygen and nitric oxide to tissues, stimulate breathing, dilate blood vessels. Overbreathing can constrict cerebral blood vessels, reducing brain metabolism and compromising executive functions. Myth 4. I believe this is one of Saul Rosenthal's favorite myths. The key to healthy breathing lies in its efficiency. It doesn't lie in its depth. Efficient breathing using the diaphragm, and we call this diaphragmatic breathing, allows for optimal gas exchange in the lungs. The quality of the breath, involving complete oxygen and CO2 exchange, is far more important than the volume of air inhaled. This is a quote from Chris Gilbert, and it will require some nuance. Fast breathing is okay, and deep breathing is okay, but not both unless you're exercising heavily, dumping more CO2 into the bloodstream. Now, here's the nuance. Fast breathing is not always appropriate, particularly when it is not part of exercise. Fast breathing, when not paired with an increase in tidal volume, reduces alveolar ventilation efficiency because there's a greater proportion of each breath that's lost to dead space ventilation. And this inefficiency means that less oxygen is inhaled, less CO2 is expelled, and the overall work of breathing increases unnecessarily. Fast, shallow breathing can contribute to dynamic hyperinflation because rapid breathing tends to favor inspiration over expiration. Lung volume progressively increases with each breath, increasing the elastic work of breathing. Breathing becomes harder and less efficient. So we really do not want fast, shallow breathing under normal resting conditions. Breathing deeply without maintaining the correct balance between oxygen and carbon dioxide can disrupt the body's gas equilibrium and therefore pH. The physiological benefits of breathing, and there are many, are maximized when there's a proper balance, supporting cellular respiration and maintaining blood pH levels. For some individuals, especially those with anxiety or panic disorders, taking deep breaths without proper technique or guidance can lead to hyperventilation. This excessive breathing can decrease CO2 levels too much, potentially causing symptoms like dizziness, palpitations, or increased anxiety. Discourage typical deep breathing. And what I mean by that is where a client inhales a massive breath and inevitably exhales too quickly, because this promotes overbreathing and expels too much CO2. Our colleague Don Moss no longer uses deep when coaching breathing. And I really wish that as part of their education, doctors and nurses learned about not doing typical deep breathing. I still see commercial messages on the LCD panels in my cardiologist's office that use deep in describing breathing. We need to get the message out. Myth: take deep breaths. Fact: typical deep breaths, where a client inhales a massive breath and exhales too quickly, promote overbreathing. This expels the CO2 needed to decrease blood pH and release oxygen and nitric oxide from hemoglobin. Gently breathe like you are smelling a flower. Exhaling longer than inhaling. And clearly, you don't need to breathe that deeply. Myth 5: mouth breathing is better because it's easier, since there's less resistance. Inhaling through the mouth results in greater dead space and airway resistance compared to breathing from the nose. Now, dead space refers to areas of the respiratory system where the air is present, but gas exchange does not occur. It includes the airways that conduct air to the alveoli, but do not participate in gas exchange, and alveoli that are not perfused with blood. Dead space is a problem because it reduces ventilation efficiency, since not all inhaled air reaches the alveoli for oxygen carbon dioxide exchange. Again, quoting Dr. Gilbert, mouth breathing is fine when there's a need for large amounts of air, such as exercising or when the nose is stuffed. Otherwise, encourage your clients to inhale through the nostrils to filter, moisten, and warm the air. They should exhale through the mouth or nose, depending on training goals and their health. The nose acts as a natural filter, trapping dust and allergens and other particulate matter before they can enter the lungs. Nasal passages also humidify and warm the air, protecting the respiratory tract from irritation and infection. Mouth breathing bypasses these natural defenses. Inhaling through the nose releases nitric oxide, which we've talked about already, which enhances the body's ability to transport oxygen by dilating blood vessels. This process improves oxygen uptake in the blood, contributing to better overall cardiovascular health. Mouth breathing does not release nitric oxide and confer this benefit. Chronic mouth breathing can lead to dry mouth, increasing the rise of dental decay and gum disease because saliva, which protects against bacteria and aids digestion, is reduced. Furthermore, the altered position of the tongue and jaw can contribute to malformations in children, such as dental malocclusion and facial deformities. Inhaling through the nose helps regulate the volume of inhaled air and maintain adequate levels of CO2 in the blood, which is necessary to efficiently release oxygen from hemoglobin to your tissues. Mouth breathing can lead to overbreathing and a reduction of CO2 levels, impairing oxygen delivery. Exhaling through the nose cannot be regulated in the way that pursed lips breathing can. Exhaling through pursed lips reduces inappropriate breathing volume when the cause is emotion rather than exercise demand. Again, taking Dr. Gilbert's name in vain, many people favor practicing breathing by inhaling through the nose and exhaling through the mouth. So that's a compromise between the two that makes sense. Myth: always breathe through your mouth. Fact: encourage your clients to inhale through the nostrils to filter, moisten, and warm the air. Depending on training goals and health, they should exhale through the mouth or nose. Myth 6: longer exhalations during slow-paced breathing increase HRV. My son Zachary Meehan and I systematically reviewed 11 inhalation to exhalation ratio HRV studies using the revised Cochrane risk of bias tool. We concluded that longer inhalation to exhalation ratios do not reliably increase HRV. Josh Marchant and colleagues at Brigham Young reported the same results in their recent study, and Dr. Kazan was a consultant on that study. Myth: longer exhalations during slow-paced breathing increase heart rate variability. Fact: Meehan and Schaffer's 2024 review of 11 inhalation to exhalation ratio HRV studies found that most did not confirm participant breathing rates or inhalation to exhalation ratios, and their findings disagreed. Longer IE ratios do not reliably increase HRV. Now, listen very carefully. I am not suggesting that there aren't other reasons for longer ratios to exhale, perhaps 1.5 times or twice as long as you inhale. But increasing HRV shouldn't be one of them. Myth 7: longer exhalations are healthier. We are unaware of well-controlled, randomized controlled trials confirming the health benefits of longer exhalations. Now, well-controlled means the investigators confirmed that participants breathed at the same rates and followed the inhalation to exhalation rate instructions. And you can see what the various AI platforms told us about the literature. I checked recently, there hasn't been a change. Professionals arguing that longer exhalations are healthier and equal ratios are harmful have not supported their claims with evidence from randomized control trials. For example, do longer exhalations lower blood pressure or blood sugar? Do equal ratios raise blood pressure or blood sugar? The widely used Institute of Heart Math Coherence Coach breathing pacer has used equal IE ratios for decades without incident. Slowly exhaling is useful for conscious regulation of breathing. but not the same as saying it's healthier. Anxiety management usually benefits from intentional slow exhalation and is a common therapeutic recommendation to be used strategically. Now, let's talk about individual health conditions. For people with respiratory conditions such as COPD or asthma, excessively long exhalations can lead to challenges like incomplete lung emptying or increased breathing work, which might exacerbate their condition. During physical activity, the body's demand for oxygen increases, necessitating a quicker breathing rate. Longer exhalations in these cases can actually reduce oxygen intake efficiency, potentially impairing performance and leading to faster fatigue. Effective breathing involves adapting to the body's needs and balancing oxygen intake and carbon dioxide expulsion. The ideal pattern is dynamic. It varies depending on your current activities, emotional state, and health conditions. Myth: longer exhalations are healthier for most people. And I've actually reproduced the HeartMath pacer. Fact: no well-controlled randomized controlled trials show that longer exhalations are healthier. Myth 8: 100% oxygen saturation is better than 98%. Now, oxygen saturation measures the percentage of hemoglobin binding sites in the bloodstream occupied by oxygen. Oxygen saturation between 95 and 98% is normal at sea level for healthy individuals. And if you look at this graphic, you'll see that the curve flattens out above 95%. Higher oxygen saturation, for example, 100% versus 98%, is not better because they deliver virtually the same amount of oxygen to the tissues. And this graphic just shows oxygen from the lungs bonding to the hemoglobin and then being released to the tissues. The additional 2% oxygen is primarily dissolved in the plasma. This can produce oxidative stress, blood vessel constriction, and tissue injury, especially in critical ill patients. For most adults receiving supplemental oxygen, the preferred target saturation is 94 to 98% based on major clinical guidelines. However, if you have a patient treated for chronic obstructive pulmonary disease, the lower target is 88 to 92% to avoid suppressing respiratory drive or worsening acidosis. Now, while 100% oxygen saturation is not harmful in brief or healthy contexts, such as in recovery after exercise, in many clinical settings, lower values are preferred to avoid excessive oxygen exposure. Myth: 100% saturation is better than 98%. Fact: 100% oxygen saturation does not increase its delivery to your tissues, but it can produce oxidative stress, vasoconstriction, and tissue injury, especially in critical ill patients. Myth 9: pulse oximeters are accurate for everyone. Physicians use oximetry to identify patients who need supplemental oxygen. Now, since this technology was developed using a racially non-diverse population, it shouldn't be surprising that occult, meaning undetected hypoxemia, was 3 times more likely in Black than white patients in 2 large cohorts. During the COVID-19 pandemic, patients of color were sent home instead of intensive care units due to inaccurate oxygen saturation measurements. Misleading pulse oximetry readings delayed treatments, increasing hospitalization rates, limited access to necessary medical interventions, and exacerbated existing health disparities. Professor, what is the impact of racial bias in standardizing pulse oximeters? Pulse oximeters were primarily standardized on lighter skin, exaggerating Black patients' oxygen saturation. Well, how large were the errors in patients with darker skin? In 2 large studies, these devices were 3 times more likely to misread oxygen levels below 88%. During the COVID-19 pandemic, these errors compromised the treatment of some patients of color whose oxygen levels appeared normal. So, they were mistakenly sent home from the ER when they belonged in the ICU? Tragically, yes. The physicians should have questioned these readings based on their patients' reports. Then, there are 2 lessons. Listen carefully to your patients, and inclusive standardization can be a matter of life and death. I'd like to double down on one of these takeaways. Listen to your patients. We already know when doing biofeedback and neurofeedback to question the readings that we see on our software. Listen to your patient. Trust your patient over your readings. Myth 10. Holding your breath increases lung capacity. Now, lung capacity is the maximum air the lungs can hold, typically measured in liters. It involves several components, such as tidal volume, the air inhaled and exhaled during normal breathing, and vital capacity, the maximum air exhaled after a maximum inhalation. Now, total lung capacity is determined largely by genetics, age, sex, and physical conditioning. But environmental factors and overall health can also influence it. Holding your breath can increase tolerance to higher carbon dioxide levels. It may temporarily affect how comfortably you can hold your breath, but it does not increase the lungs' capacity to hold air. This again is from Chris Gilbert. People know about Japanese pearl divers holding their breath for long times. It's not an increase in lung capacity, but tolerance for hypoxia and higher CO2, plus vigorous hyperventilating before the dive to produce respiratory alkalosis. There have been deaths by drowning reported over the years in U.S. high school pools and military situations, pushing the limits of underwater swimming. Frequent and intense breath holding can be risky, especially without proper training and supervision. It can lead to a dangerous condition known as hypoxia, which is oxygen deprivation, which in extreme cases can cause unconsciousness, brain damage, and even death. Myth: holding your breath increases lung capacity. Fact: holding your breath can be dangerous, may cause fainting, and doesn't increase lung capacity. Myth 11: slow-paced breathing is healthy for everyone. Slow-paced breathing can be highly beneficial for stress reduction and cardiovascular health. But as with so many things, it's not a one-size-fits-all remedy. Its appropriateness depends on individual health conditions, activity levels, and situations. Personalized approaches, and in some cases medical guidance, are recommended to ensure that breathing practices are safe and effective. Let's talk about individual health conditions. Slow-paced breathing might disrupt the acid-base balance in people with metabolic disorders like diabetes or kidney disease. For respiratory disorders like asthma or COPD, disruption could result from overbreathing, but this can be avoided with expert training. Now, adaptation to activity levels. During physical exertion, slow breathing might not provide sufficient oxygen intake or carbon dioxide removal, potentially causing decreased performance and discomfort. The risk of hypoventilation or underventilation. Excessively slow breathing can lead to hypoventilation, especially if the breaths are shallow. This can increase blood carbon dioxide levels, causing headaches, confusion, and dizziness. So, myth: slow-paced breathing is healthy for everyone. Fact: when disorders increase the acid in your body fluid, rapid breathing attempts to restore your acid-base balance. Slowing breathing could be hazardous in asthma, COPD, diabetes, kidney disease, and neuromuscular disorders that affect breathing. Myth 12. Abdominal breathing should feel more natural than thoracic breathing. No, there's no question that abdominal breathing has many health benefits, and it is clearly effective for relaxation and efficient breathing. But saying that it should feel more natural than thoracic breathing for everyone is an oversimplification. Various factors influence breathing patterns, including your structure, health conditions, activity levels, and learned behaviors. Training. Abdominal breathing can be learned and it can become more natural with practice, especially in contexts like yoga or meditation. However, initially, it might not feel as natural, particularly if you have been predominantly a chest breather. Physical differences. People have different builds in physical and anatomical structures, affecting how comfortable or natural a particular breathing style may be. For some, thoracic breathing may feel more natural, especially during certain activities or due to their physical conditioning. Health conditions. Those with respiratory issues or certain medical conditions might find abdominal breathing more difficult or less natural. For example, individuals with obesity or abdominal pain may find thoracic breathing easier. Activity. During vigorous exercise or stressful situations, thoracic breathing can feel more natural and effective in meeting the body's increased oxygen demands. This is fight or flight. Conversely, abdominal breathing is more beneficial in calm, restful states or during relaxation and stress reduction. Myth: abdominal breathing should feel more natural than thoracic breathing. Fact: initially, abdominal breathing often feels uncomfortable for thoracic breathers. After weeks of practice, abdominal breathing may require less conscious supervision and effort. Myth 13. You should breathe slowly throughout the day. When breathing slows excessively, the lungs do not expel enough CO2, and you accumulate it in the bloodstream. This is called hypercapnia. This can cause respiratory acidosis, resulting in confusion, fatigue, and shortness of breath. Slow breathing could be hazardous, as we've said, depending on the diseases your client suffers. Overbreathing to compensate for abnormal acid-base balance and slow-paced breathing could endanger your health. Maintaining a slow breathing rate, regardless of physical demands, can prevent the body from properly adjusting to different activities, potentially reducing overall efficiency and responsiveness. Adopting an adaptive strategy that adjusts to current needs is better. For example, employing slow breathing techniques during rest, stress, or meditation can be very beneficial, but allowing the body to increase breathing rate during exercise or excitement is crucial for optimal physiological function. Myth: you should breathe slowly throughout the day. In fact, your breathing rhythm naturally changes throughout the day to meet the body's demands. During exercise, your body needs more oxygen, leading to faster breathing. Slowing down your breathing at this time would deprive your tissues of the oxygen they need. Final myth: the Wim Hof method involving rapid breathing and cold exposure is healthy. Now, this method, popularized by Wim Hof, also known as the Iceman, involves rapid breathing techniques, cold exposure, and meditation. While it claims numerous health benefits, and it really does have a substantial following, it's important to approach the method with a nuanced understanding of its potential benefits and risks. Hyperventilation. The rapid breathing aspect can lead to hypocapnia, and this can cause symptoms like dizziness, tingling, confusion, and even fainting. Cold exposure. While brief cold exposure can boost the immune response and metabolism, prolonged exposure without proper adjustment can lead to hyperthermia and cold-related injuries. Individuals with cardiovascular issues may be at higher risk when exposed to extreme cold. Medical conditions. Cardiovascular diseases, respiratory issues, or high blood pressure should be cautions, and you really should consult with a healthcare provider. Lack of scientific consensus. Although some studies support some aspects of this method, the research is not extensive enough to conclusively determine its purported benefits or long-term effects. More rigorous peer-reviewed studies are needed to understand its impacts on various health aspects. The claim that it's universally healthy overlooks many issues and the lack of scientific validation. While there may be benefits, they must be weighed against potential risks. Anyone interested in this method should approach it with caution, ideally under the guidance of a healthcare professional, and also to consider their personal health and risks. And finally, myth: the Wim Hof method involving rapid breathing and cold exposure is healthy. Fact: the Wim Hof method can produce dizziness, tingling, lightheadedness, and fainting. It may be contraindicated in cardiovascular disease, epilepsy, or severe asthma. So here is the conclusion. And Mitch, I would love those questions from chat if we have them. And if you'd unmute.
There we go. Okay. Yes, we certainly do. I will say, one person asked about how you measure CO2 and tidal volume, and that was, answered in the chat by Chris Gilbert, who
Your state is taken in vain quite a few times.
who talked about getting a capnograph. Would you say something about capnography and the various devices that are available and the various price ranges? Because I think people have an interest.
There, you have a number of choices that are currently available. The current range is somewhere between uh, $1,800 to the 3,000s, uh, because we're trying to keep presentations free of commercial bias. Uh, I will not mention the brands, but if you email me, I can provide you with some that I'm aware of. Of course, there also are freestanding units that are not linked to software that are designed for ERs and medical practice, but it's called a capnometer, and you have several choices currently. Uh, the cost is daunting for many professionals, but as Dr. Gilbert can attest, it it can be, if you can afford it, it can up your respiratory training game.
Thank you. A couple of people asked in various ways, what would you recommend the best way for a person with panic disorder to breathe, both when they feel one coming on and then also if one happens?
Uh, if Dr. Gilbert is still in the house, can we give him the floor? I am not a clinician, and I try really hard to stay in my lane. Uh, and if he's not in the house, uh, Saul Rosenthal uh, would be another wonderful choice. Do we have a clinician that can field that question?
I am in the house, if you can hear me.
I can hear you perfectly.
Okay. Um, the reason to hold your breath, it's really helpful for people with panic attacks or have developed a fear of suffocation, because the higher the CO2 in the bloodstream, the more urgently you feel the need to breathe. So um, many clinical procedures have been developed to increase your tolerance of CO2, basically to not get so scared when you feel that you're running out of breath. It's a natural fluctuation in the blood gases. And by holding your breath for even 15 or 20 seconds and not getting panicky about it, it it's what's the word? Exposure,
Mhm.
conditioning. You get used to that feeling because you know as soon as you breathe in, feeling goes away. You get new oxygen and you breathe out, the CO2 goes away and it's normal again. So I've taken many people through that kind of experience, from terror and holding out breath to pride and being able to tolerate the CO2 without panicking.
During the pandemic, I had read or I had heard that one of the benefits of breathing through the nose, inhaling, is that it does release nitrous oxide, which is a, antiviral. Is that true?
Again, that would take me outside, way outside my lane. Uh, however, uh, I've always been willing to take gambles. Uh, I've never I have never seen any evidence that this moves the needle with respect to your vulnerability to COVID infection. But I don't believe there has been any systematic research about that. So yes, nitric oxide can function that way, but here we're talking about a very aggressive virus. Uh, and in the same way, we don't assume that increasing nitric oxide release will protect us against cancer or the common cold. So I would like to see the data. I've seen nothing about that.
Hold on, things are changing fast. So, are there any particular factors that can interfere with taking a full
Oh yeah,
diaphragmatic?
childbirth, uh, surgery, abdominal surgery, chest surgery, morbid obesity are among some of the more common factors that can interfere. So there are structural reasons and functional reasons why it can be difficult. Again, one of the things I want our viewers to take away is to effectively breathe. You don't have to inhale large volumes. You simply have to inhale the volume that you'd use for smelling a rose. And that, by the way, is an example that comes from Dr. Ina Khazan. And I thought it was brilliant because it makes it concrete for our audience. Just the force required to smell a rose. Are there other questions?
Yes, there is a question about something which I'm frankly not that familiar with. Butaco breathing. Okay, it says this involves a closed mouth breathing even during sleep using tape and exhaled, and then there's a question if this is anything that could have positive effect for asthma, and does it go against something that was said earlier in your talk about slower breathing for asthmatics?
That, once again, as a medical question, would take me way outside my lane. Dr. Gilbert may be familiar with this breathing protocol and and the health concerns about it, as well as its effectiveness. And I would invite him back if you would like to comment on it.
It's okay with me, but I'd like to hear the question again. I was responding to another text message.
What about butaco breathing for asthma? This involves, and it says what it involves.
Yeah, they make a lot of claims, but it hasn't completely held up with a lot of examination. It's just kind of in the medium ground. Might help, but there's a person in Australia we've been in contact here and there. She really studied butaco breathing very deeply and became a really fine clinician. She has a doctorate in breathing, believe it or not. If you contact me, I can give you contact information. She knows more about butaco breathing than anybody alive. I think butaco is dead now.
Okay, it is 3:30. I am going to say, Fred, thank you very much. I found this very, very informative, so I assume others did, and as well. There are some questions here that have not been answered, but Fred, you graciously offered that people could reach you via email, I thought.
Yes, I did. I stand by that. And I will make it clear when I should not be the one answering the question. So if it turns out that it, for example, is a clinical medical question, I will say outside my lane, but here's someone you can reach out to.
Fred, thanks a lot. This was very good. We appreciate you, and thank everyone for your attendance and your attention. So have a good rest of your week, everybody, and thanks a lot.
Thank you.
Bye-bye.
Bye now. And Chris, you've been awesome. Thank you so much for making this a great presentation.
Well, everybody needs a hobby. Breathing is mine.
Okay. Take care now.
Bye-bye.
Bye.